A very warm welcome to everybody to this webinar. This webinar is happening as part of the WHO and Religions for Peace Global Conference. This is part of the track that is the theme of which is collaboration in health emergencies, WHO, faith partners, and national governments. We really are delighted to have you all joining us today, wherever you are in the world. And I am going to hand to Dr. Francis Curia, our co-host. Dr. Curia is the Secretary General of the African Council of Religious Leaders for Religions for Peace. And Dr. Curia is going to give some opening remarks. Welcome, and over to you.
Thank you very much, Sarah. And greetings to all the people attending this webinar and conference on how to tackle world health emergencies. And we want, on behalf of Religions for Peace, I want to thank WHO for partnering with us in this webinar series and in creating the knowledge that is necessary to prepare our populations for the challenges that lie ahead. As common with us, I will now ask all of us to start this with a word of prayer. We always ask everybody to do the prayer in the way they pray best. So we are going to give it 1 minute of silence so that everybody can pray in the way they pray in their faith. So 1 minute of silence for prayer and reflection. Welcome all of you for prayer. Amen. Thank you for your reflections and for praying. As we know, we are having a troubling global pandemic around the COVID, and WHO has been very generous and very supportive to religious leaders in partnering with them to help our communities to deal with the COVID-19 pandemic. We are very glad that today we are going to be looking at the situation and the case study of Zimbabwe, where I am right now. And I welcome all of you to participate in this webinar. And because we have a lot to discuss, I then hand it over to Sarah to take it up to the next level. Welcome, Sarah.
Thank you very much, Dr. Curia. And yes, as you mentioned, today we have colleagues and partners and friends from Zimbabwe to share with us their experience of collaboration. As you all know, we had, or maybe you don't know, but we had the case study of Kenya presented yesterday and Zimbabwe today. And these case studies really are showcasing different models of collaboration at a national level. And so we're very excited to have this opportunity to learn. So for opening remarks, I would be very happy and honored to hand over to my colleague in Zimbabwe, Mr. Nkosi Mpala, who is an infections and hazard management officer in the country office, the WHO country office in Zimbabwe. Over to you.
Good afternoon, colleagues. My name is Nkosi Mpala, as Sarah has already said, and I'm standing in for the WR, Dr. Alex Kasasira, who would have loved to be part of the proceedings, but due to other competing events, he couldn't join us. And also apologies from our colleague, Priscilla, who could not join us. But I know that is someone who is really passionate about risk communication and community engagement. And I just want to thank the HQ for organizing this event. And as WHO Zimbabwe, we really thank you for the technical support. during the process. Then maybe before I delve into the gist of the matter, I just also want to commend the government of Zimbabwe, Ministry of Health, Zimbabwe Council of Churches, and other religious partners for really convening this important event. And we realize that for us to really realize collective gains, we really need to put our heads together, and the SWHO will continue with partnerships across the partners. And this is an important event, as it also allows us to gel with the communities, as we realize that community engagement is the core of what we do as WHO, and it's something that we are going to continue to collaborate on. And when we look at also the partnership that we have with the clergy, it also allows us to come up with contextualized interventions which are holistic, which are sort of integrated, and it also allows us to have that touch with the communities, and in the line of the development, humanitarian, and peace nexus that the humanitarian sector is pursuing. Then I think together we can really realize good outcomes, especially in this COVID-19, which has sort of brought a stake reminder that we should collaborate, we should work together, we should put our hands on the deck to ensure that at the end of the day, we realize those collective outcomes. So this is just the short in terms of the welcome remarks, and welcome everyone, and we look forward to further collaboration even beyond COVID-19 as we realize the universal health coverage, which is the foundation or the bedrock of all our health interventions. Thank you so very much, and over to you, Sarah.
Thank you very much, and I couldn't agree more. I think the collaborations and partnerships that we established during the crisis are definitely partnerships and collaborations that can help to achieve universal health coverage. So for this next portion of the webinar, we're going to hand over to some colleagues who are going to talk a little bit about the background of how these partnerships developed. And our first speaker is Mr. Chinakidzwa from the Ministry of Health and Childcare in Zimbabwe. Welcome, Mr. Chinakidzwa, and the floor is yours. Mr. Chinakidzwa, we don't hear you yet. Would you like to unmute? And you're welcome to go ahead.
Good afternoon.
Good afternoon. I hear you now.
My name is Onias Ndoro, but somehow I'm seeing my name appearing as Mr. Chinakidzwa on the screen. Maybe Mr. Chinakidzwa has not joined or something. Okay, I see it's joined.
All right, that's I think an error with the naming. So, Mr. Chinakidzwa, are you with us here today? Under a different name, perhaps? All right. Perhaps we can come back to Mr. Chinakidzwa, and I will rename you Mr. Ndoro. I'm very sorry that your name appeared in differently. So I think we
forwarded the link to me. That's why it's appearing.
Right. Okay, I understand now. Okay, I will rename you, and let's move on then while we wait for Mr. Chinakidzwa. I'd like to welcome Mr. Nkosi Mpala again. I believe you were the second speaker anyway in this session, so perhaps you want to go into your presentation about the partnerships. Mr. Nkosi Mpala, back over to you.
Thank you very much, Sarah, for this opportunity once again. The presentation is that side, but my presentation in terms of the structure, I'm going to look at just the overview of COVID-19 in Zimbabwe, then look at the partnership and the cooperation that we had with the clergy, then also talk about one or two lessons learned from the initiative. I will try superficially so that my colleagues will dive deeper into the matter. Next slide, please. This is just a summary of COVID-19 in Zimbabwe. This is the EPI curve, which shows distinctly that we, as a country, we have had 3 waves. The one that we experienced in July 2020, the other one from December to January 2021, then the catastrophic one, which we experienced from June 2021, and they ended up around 20 August in 2021. So these ones really shows the cycles of COVID-19 that we had. Next slide, please. So in terms of working with faith-based organization, you realize that in terms of our intervention, risk communication and community engagement is one of the pillars that we pursue in terms of COVID-19 response. And it is through that pillar that with the leadership of Ministry of Health, as well as the Zimbabwe Council of Churches, as well as UNICEF and other faith-based organizations, we managed to come together to come up with strategies and ways and means to reduce the COVID-19 pattern, which was a bit high in terms of around August. So this came at a realization that with partnership with the faith leaders, surely we can do more, and realizing the interface that they had with the communities. So we started having those seminars at national level and at provincial level, with all the thrust being to break the transmission of COVID-19. Next slide, please. This is just it shows the Twitter handle in terms of the interfaith workshop that we had, supported by the Ministry of Health, as well as UNICEF and the Africa University. So you realize that it was many hands on the deck, but with the thrust to come up with a collective outcome of breaking the transmission at community level. Next slide, please. In terms of the workshops that we had with the faith-based organization, the main thrust was really to improve in terms of COVID-19 IPs, infection prevention and control, as well as the funeral management. But in the whole gamut of that, we also wanted to create awareness in terms of COVID-19 in the country. Then we also wanted to strengthen the public health and social measures that were sort of called upon by the government to break the transmission. So the churches, as well as the traditional and religious leaders, really offered that avenue for us to be in touch with the communities. And one of the things that the churches also really played a pivotal role is on vaccine hesitancy, where they created that awareness in terms of vaccination. And I'm happy and glad to say that as of yesterday, the country was around 38%, which is quite a milestone. And I think the collaboration with the faith colleagues really contributed to that. And the other thing that the working with the faith-based organization is on psychosocial support. Upon realizing that it was a sort of a big elephant in the room, and the interfaith groups managed to really play a pivotal role in ensuring that that aspect is covered. Next slide, please. I've already talked about the mental health issues, and the other issue that we really wanted to pursue under this is to promote inclusivity, especially in the information dissemination, realizing that the clergy is in touch with the communities, and at the same time, they can come up with messages and decode it according to the literacy levels of the communities. And you also realize that it also meant a reduction in terms of door-to-door campaigns, which at the end of the day also expose programmers. Next slide, please. I'm going to just maybe delve on some of the lessons learned. There is quite a lot, but I will try maybe just to pick a few in terms of the lessons learned. The first one being, we realized that community engagement through the community leadership in conveying COVID-19 message was powerful, and we realized the gains in terms of the awareness that was created in the communities. Then we also realized that in terms of one of the amplifiers of COVID-19 was the funerals. So the faith communities really played a pivotal role in ensuring that in funerals there is that adherence to public health and social measures. Then the other preventive strategies, which are sort of age-based and appropriate, we're also coming out through the clergy. Then the family support system, we realized that COVID-19 also brought along stresses, and the clergy really played a pivotal role in ensuring that there is that social cohesion, which is quite crucial in terms of COVID-19 response. Then the other is that it came up with a sort of centered on it came up with the issues to address challenges which were centered on religious gathering, as well as changing way of doing things in terms of managing funerals. Next slide, please. Then I think Sarah talked about the misinformation and disinformation. We realized that the clergy really played a pivotal role in countering misinformation and disinformation, especially working collaboratively with the Ministry of Health, who were really responsible for packaging the message that suited the context, as well as aligning to the target group. Then during the planning process, we realized that there is need to really involve the faith and traditional leaders from the planning process, from the project design, so that at the end of the day they journey with the program implementation, and they shouldn't come in as an afterthought. But I think from the early stages of engagement, they should. It's one of the best practices to ensure that they move along. And one of the things that also was one of the lessons that we picked, we realized that there is the need to continue cementing or establishing the relationships that we have with the clergy and the traditional leaders, and they have that open door policy to ensure that there is that frank and courageous discussion on issues that affect COVID-19. Slide. Thank you so much. So this is just a summary in terms of what we did and as a country. And I think my colleagues and the other partners are going to dive into other pertinent issues that are really relevant to this discussion. Thank you so much, and over to you, Sarah.
Thank you very much, Mr. Nkosi and Mpala. I think it was a wonderful introductory presentation. I now, I believe Mr. Chinakitswa is still not with us today yet, so I think still trying to join, but I would now like to hand to Mr. Titus Moetsabi, the Communications for Development Specialist from UNICEF Zimbabwe. Welcome, Mr. Moetsabi. You have the floor.
Good afternoon, Sarah. Thank you for inviting us to participate, and greetings to all delegates on the webinar. By way of context, I would like to say my social development career started 33 years ago in Zimbabwe as a refugee officer for the Lutheran World Service, and I was responsible for refugees in SADC, while based in Harare. So this is important by way of context, because I come from that religion and social development background, even outside, as a precursor to my work with UNICEF and partners in public health emergencies. I have two experiences. The first experience was working with UNICEF and WHO and the government of Liberia from the same compound in Monrovia during the Ebola response, as well as in Sierra Leone. And as my colleague from WHO has already mentioned, we found the intrinsic trust and goodwill of religious leaders very appropriate in dealing with transmission related to burials, as well as other religious rites, such as baptisms, and both bishops and imams and other Islamic scholars collaborated very closely in raising awareness and information to save lives in the Ebola response. I was also the UNICEF representative to the United Nations mission on Ebola response in Ghana, UNMIA. And at that regional level, religious leaders in every country were involved in both the planning and the response to that public health emergency. Here in Zimbabwe, more intimately and appropriately, yesterday, I was one of the delegates at the launch of the Zimbabwe Interreligious Council, and Dr. Kuria and other colleagues on this webinar were there at this event, which was officiated by the Minister of Public Service, Professor Paul Mavima, who actually underlined the very important role religious leaders and faith-based organizations play, not only in public health emergencies, but generally in the context of fostering peace, harmony, unity, and working hand in glove with governments to make sure that our communities transform sustainably in all multi-sectors. So in the context of the Zimbabwe Inter-Religious Council, UNICEF is collaborating very closely with government, WHO, and faith-based organizations under the umbrellas of the Council of Islamic Affairs, the Zimbabwe Catholic Bishops' Conference, the Zimbabwe Christian Council, as well as the Union of Development of Apostolic Churches. And when I say collaboration, I mean that we are working closely together in terms of formative research, both qualitative and quantitative, and rapid assessments to establish the awareness, knowledge, the attitudes, and practices that faith leaders and faith influencers can focus on to address COVID-19 responses. We are also working with faith-based organizations and their frontline health workers and social mobilizers in terms of social listening, gauging perceptions, and measuring those perceptions, which might contribute to, for example, non-adoption or slow adoption of vaccination, whether it's first or second doses, so that communities can be persuaded to understand the importance of herd immunity. We also, therefore, feel once we have collaborated at the research and formative analysis stages with faith leaders and their frontline workers, it is imperative for them to be involved in micro plans for micro village strategies, plans and budgets to address COVID-19 responses in the villages, in the wards, as well as at district and provincial level, working every time with the Ministry of Health, health promotion officers, doctors, and other community health workers. It's very exciting because faith-based leaders are organic to communities, so they are trusted by communities. And it is this trust dividend that we ride on to eliminate public health emergencies or reduce their destruction and disastrous consequences, as well as quick recovery by communities. Of course, in Zimbabwe, most of us came through mission schools and hospitals. So faith-based organizations have also very robust supply chain systems. And these have been tapped into by UNICEF, WHO, other organizations, as well as government to reach the first mile or the last mile, depending on how we look at it. Lastly, I want to say that on a long-term basis, most of these public health emergencies are also propagated by social norms and values, and faith leaders are very central to addressing values and social norms. And I personally believe that spirituality is very, very cardinal to healing. And therefore, I do not see all the healing happening from COVID-19 without the facilitation of faith-based organizations. I also want to say that there is a very intimate...
Very sorry to interrupt, Mr. Moetsabi. We might need to move to the next speaker relatively quickly, but...
Thank you.
Thank you.
My last 2 points are: one, that faith leaders, WHO, UNICEF, government have been collaborating on science and social sciences, psychology, and other matter disciplines, theology, with the religious leaders to actually address public health emergencies as well as social behavior change. But the key lesson is that we all need each other in order to successfully counter the spread of health epidemics. And therefore, I just want to thank the magnanimity and maturity of all parties, because collaboration is not easy, because we come from different ideologies and discourses, but we're able to sit at the same round table and actually address the root causes and social drivers and behavioral drivers which need to be addressed to stop public health epidemics. Thank you very much.
Mr. Moetsabi, thank you so much for a very powerful intervention, and I'm very sorry that we had to rush you towards the end. I hope that we can continue the conversation in another forum at some point, so thank you very much. I believe that Mr. Chinekutswa has just joined us, actually. I've just seen him pop up, so that's amazing timing. I'm not sure. Welcome, Mr. Chinekutswa. Are you connected and able to present? I don't want to put you on the spot the minute you joined the webinar, but it's great that you were able to join after technical difficulty. Mr. Chinekutswa? All right. All right, I think he's still potentially having some trouble, but I'm very glad to say that we have another colleague from the Ministry of Health and Childcare, Ms. Rumbidzai Chimukangara. So Ms. Chimukangara, I wonder if you wanted to say a few words on behalf of the Ministry of Health and Childcare. Over to you.
Okay, thank you very much, Sarah. I think I can present on behalf of Mr. Chinakizwa, so you can put through the slides. Thank you. Okay, good afternoon, everyone, colleagues. I'm going to discuss the development of partnerships among the Ministry of Health, WHO, and other faith partners in Zimbabwe. Can we move to the next slide? So, as an introduction, Zimbabwe is a religious country, and we have various religions, including Christianity, Muslim, and those who subscribe to the African tradition. And some of these people from these different religions are related to each other biologically. So working together is easy. These people live peacefully in the same communities, and they participate equally in community events. And although there are ideological differences, so the Ministry of Health and Childcare saw it easy to work together with faith partners from different types of religion to address challenges of the COVID-19 pandemic. Next slide. The belief in following a multi-sectoral approach and leaving no one behind influenced the need to work with these groups and religious groups, since they make a large proportion of the communities in Zimbabwe. We saw that working with them will make RCC messages spread faster in the communities, and their leaders have a lot of influence, hence have the power to influence behavior change. Thank you. Next. In Zimbabwe, we have always been working with faith partners back then. However, with the introduction of the COVID-19 pandemic, this has managed to strengthen our partnerships as faith partners have been actively working in the response for the pandemic. And for the first time, we have, in the history, we have seen no prophets and traditional leaders proclaiming a cure for the COVID-19 virus, as compared to what we had in the HIV and AIDS pandemic. So because of this, we engaged them early, and we have seen that working with partners is quite, faith partners is quite a best practice for us. Next slide. So WHO has also been weather friend for the Ministry of Health and Childcare for a long time, since they offer technical and financial support for the ministry. And whenever the ministry has partnerships with the faith-based organizations, WHO is also represented, and they also are given platforms to relate to the faith-based organizations. These faith groups now see WHO as part of the response to the pandemic, to the extent that some of them are now working and tying up with the WHO and Ministry of Health and Childcare. Next slide. So for the to explain the base of the relationship, we do have good working relationships, which were established before the health problem occurred. We also respect the different ideologies, which allows the different faith groups to work together. There's also building of trust and also being professional in our approach. And so this strengthens the collaboration. Next slide. So these are basically the areas we've been collaborating on. We have had combined trainings for Christians, Muslims, and the African traditional religion. Most of these faith-based organizations are members of the National Risk Communication and Community Engagement Committee. We also collaborate in the development of strategies and educational materials and conduct education in the community together. Faith-based organizations, partners are also offering psychosocial support to affected people, since most individuals would like support from their religious leaders. And we also have become a bridge between the community and the health system. So the faith partners have become really a bridge, and they are passing on the accurate information that the community needs to hear. And part of the community feedback mechanisms also, because when we do collaborate and for our meetings, we get to receive feedback from the community on how we can strengthen our response. So thank you so much.
Thank you very much, Mbizai, for stepping in and speaking on behalf of Mr. Chinakizwa and delivering the presentation. I believe we're lucky enough to have you back later on in the webinar as well. So thank you. I'd now like to hand over to my colleague, Vivian Mugarisi, who's the Communication Officer at WHO in Zimbabwe, and who's really done a lot of the hard work in pulling this webinar together. Vivian is going to moderate the next portion, which is for us to be able to hear the voices from the faith partners in Zimbabwe. So Vivian, over to you.
Thank you so much, Sarah. Indeed, religious leaders are very key in disseminating information in our communities, and they've played an important role, especially in the context of COVID-19. So to start and hear contributions from these leaders who have done this amazing work, I would like to give Reverend Kenneth Mutata, who is the Zimbabwe Council of Churches Executive Director. Over to you, sir.
Thank you very much for having me here on behalf not only of the Zimbabwe Council of Churches, but other ecumenical faith partners with whom we have been working in response to COVID-19. I think it is important, just as a background, for us to remember that the church remains one of the key health providers in Zimbabwe, with more than 60% health provision, especially in the rural areas. And when the COVID-19 struck, we know that many people moved from the urban areas to the rural areas, because their livelihoods in the urban areas had been affected by the lockdowns. And this put a lot of burden on the rural hospitals, where the church is predominant in provision of health. We also know that when the pandemic struck, there were many myths that were driven, and some of them had a religious character, and some of them were actually driven by religious leaders. This put the church in a very significant position to counter and to provide alternative information that was truthful and factual. Last, in this context, we also know that at the time of the pandemic, the health sector was struggling from the strikes of doctors and nurses, which put a lot of pressure on the health system. In order for us to provide our intervention as the church, we had to come up with a strategy which was guided by the following issues. First, we needed to establish a collaboration infrastructure. In other words, we had to agree that this work was wide and the church needed to support the initiatives of government. The church needed to establish a collaboration with UNICEF and the World Health Organization. Secondly, we needed to establish a communication and awareness strategy. We also agreed, third, that our strategy would have a holistic treatment approach. Fourth, that our policy engagement and advocacy plan needed to be clear. Last but not least, we also needed to think through how we were going to have our post-COVID-19 recovery process. Now, if I just give maybe some highlights on some of these collaborations, it will be important for us to highlight that as a church, of course, we're taking advantage of our social capital, how we are trusted by communities, our very strong communication networks, our knowledge and expertise and experience, especially on how communities interact in the rural areas, and our levels of influence and ability to organize, and the fact that we are also providers of health and are present in almost every corner of the country. This gave us so much advantage. In terms of our collaboration, the Zimbabwe Council of Churches, of course, as I've mentioned, engaged various collaboration partners, and we have very good examples I can highlight here. For example, we had this fantastic collaboration with the Ministry of Health and the World Health Organization and UNICEF on COVID-19 vaccines for people with disabilities. This was a very important process because it came at a time when the churches had just adopted its inclusion agenda. And for this reason, people with disabilities became a very important component in our campaign to access COVID-19 vaccines. The other key intervention that we had together with these partners was the Safe Funeral Management Program. This was very important because pastors are at the front line, not only when people have died, but when people are sick, when people are fearful, when people are uncertain. Because in the context of a pandemic, many people are not sure how to manage the situation. It is this uncertainty it creates in people, and they look for at their pastors and their church to give them guidance. And we had to prepare clergy for this, because we had realized that we had started to lose some pastors through deaths as they were entering into areas that were exposing them to infection. Through the support of UNICEF and the World Health Organization and the Ministry of Health, we also managed to provide them with PPE, not only to the pastors, but also to the hospitals that we were supporting. The next, I think, key intervention was we realized that many people's livelihoods have been affected, as we have noted. And one of the key interventions of the church was to make sure that we provided foodstuffs so that we made sure that especially children under 5 and their mothers who were lactating can still maintain a certain level of health in this period where they were not able to fend for themselves. One of the major challenges of COVID-19 was its impact on the psychosocial dimension of the population. And of course, you know that the churches were closed and therefore people could not come to their pastors for spiritual guidance. But we had to establish, to conduct nationwide trainings for clergy and for lay leaders so that we could provide safe psychosocial support for those who were affected and infected, and their families during this period. And our collaboration here with the Ministry of Health and Child Care, the Department for Social Development, and the various levels of social ecumenical leadership was very helpful. During this period, of course, we realized that ecumenical collaboration among churches and church different bodies was important, but we also realized that it was important to extend this relationship to other faith groups that do not necessarily belong to the Christian tradition. And of course, this culminated actually in yesterday's, in the last 2 days, formal launching of the National Religious Council, of which the Zimbabwe heads of Christian denomination to which we belong was asked to provide the General Secretariat. So in other words, this also allowed us to increase the infrastructure for collaboration, not only during COVID-19, but beyond. Over 900 ecumenical health champions got training during this period. This is a huge number because these are voluntary people who would disseminate the message within the faith communities, and they would champion the dissemination of positive news, accurate news, factual news to the different sectors of society. And maybe the last two important point I should highlight is where do we see these kinds of collaboration going forward? Because I think we have learned a lot from this. First, I think it is important that we need to define and strengthen, to redefine and strengthen these relationships between faith-based organization and World Health Organization, UNICEF, and Ministry of Health, because we have a lot to do in common. We must focus on institutional strengthening of faith-led health infrastructure. We need to strengthen skills transfer, especially related to research and data management. We also need to make sure that faith-based organizations as facilitators and contextualizers of scientific language within the respective religious communities, where they translate this scientific language into comprehensible religious language. This work is not something that is a side dish for the World Health Organization and UNICEF. This is central on how communities can be completely mobilized. Churches also need to strengthen their capacity on policy engagement, because we realized that during this time, there were many policy engagement challenges that required the church to be at the same level with government. And we saw that with time, there was a convivial ways of engaging on policy matters, but there were so many challenges at the beginning. And we believe that I think as we move forward, this capacity for policy engagement and then translating policy and cascading policy to communities will also be very helpful. In our one of our, I think, greatest achievement was how we managed to strengthening rumor training and myth-busting approaches through the church, various church structures and public media and social media. We think that the use of social media has become very important now. Now that mobile phone penetration in Zimbabwe has surpassed 95%. It is very important to realize that we will need to find ways of using these tools to address psychosocial issues and as well as reaching out to communities that are on the margins. I think the role of the church in post-COVID response will remain very important because right now we realize that the infrastructure that are run by the church that have been dilapidated over the years will need to be strengthened, and we think that cooperation here will remain very important. I think for now, this is important for us to start a conversation. I'll be willing to take some questions in this regard.
Thank you so much, Reverend Mutata. Indeed, there's need to strengthen the partnership as we go forward. Over the years, we've had challenges in making sure that the apostolic sect has come in and seek health services, and it has taken a lot of advocacy to make sure that they take part in all the health activities that happen in the country. And we have been seeing some changes, especially when the COVID-19 started. And I would like to call Ms. Tendai Gudo, who is the Apostolic Women Empowerment Trust Executive Director, to tell us about the journey she has gone through in engaging the apostolic sect and ensuring that they have the right information, especially around COVID-19. Thank you so much.
Thank you very much, Vivian. Good afternoon, good morning, good evening, everyone. I would like to thank WHO for inviting us to present on this webinar today. So I'm going to go through the shared screen. Apostolic Women Empowerment Trust was formed in 2016 with the special emphasis to empower the apostolic community. And historically, Aweti has been involved in mass mobilization of vaccine uptake in with the main focus of the apostolic community in Zimbabwe, especially focusing on the 6 killer diseases. We managed to work with WHO, UNICEF, and Gavi on typhoid and cholera vaccination. And we managed to engage with the apostolic community, especially with the leaders through mass mobilization, sensitization, co-creation, and also a lot of training. Next slide, please. Next slide. Thank you. So since the onset of the COVID-19, Aweti has been working with UNICEF with the support from Ministry of Health. We managed to work within the community since we are a grassroots organization, and we work within the communities. And from there on, with the support from the RCC Mpala, we managed to train communities which we've been working from. And we trained behavior change facilitators, we trained village heads, we trained religious leaders, and we have been working with the Muslim community, the Christian community, the African religious community, and also the apostolic community. And from this trainings, we managed to focus our trainings on raising awareness and also trying to make sure that people, they really know what the COVID was all about, or the coronavirus was all about. And also our main focus was on infection prevention and control. We had to target the hotspots which were being reported within different provinces or different districts. And most of those hotspots were the churches and also the large gatherings which were there, the funerals, the market stalls, where a lot of people would gather, even engaging the artisanal miners, because during the lockdown, it was very difficult to just control people and say, you are no longer supposed to be going or doing what you are doing. You're supposed to be indoors. So it was kind of difficult because a lot of people were after their livelihoods. So we had to train the behavior change facilitators within our communities and the village heads so that they will be in a position to help the people within their communities, especially with the Apostolic community. We had to raise awareness, and we had to engage all these leaders with the support from Ministry of Health and Childcare, as well as UNICEF. Next slide, please. Next slide. Sorry, Vivian, next slide. Thank you. Sorry, the previous one. Yes, thank you. So AWET was working in 52 districts, and we were covering 8 provinces. And from all these provinces, we had behavior change facilitators, and we were targeting 36 behavior change facilitators in each and every district that we were working from. And also we were targeting 1,872 wards, which we were covering. And also we were also working with different leaders from different religions, and also including the Apostolic community. Next slide. The key activities which we had during our campaign since the onset of the COVID-19 were to target the village heads within the different districts we were working from. And we were working from different villages. So we had to target village heads because, you know, in terms of influencing social norms and also practices, and which pose community transmissions, which in this fact, it was management of funerals and also management of large gatherings. So we had to engage the village heads, and also from the village heads, we also had apostolic leaders as well. And in terms of also vaccination campaigns, they also played a very crucial role in terms of mobilizing communities to get vaccinated. And with the interfaith leaders, we were also working with different leaders and who mobilized communities, and who were also the first respondents in terms of the vaccine uptake. So they were the ones who were like more of the role models within within their churches and within their spaces in the communities. Next slide. I think from those pictures, you can see people in action, our behavior change facilitators in those t-shirts, either blue, green, and orange. They were involved in raising awareness, targeting the hotspots. I think you can really see you know, the behavior change facilitators engaging with the apostolic community, also engaging with school children, because there was a lot of, there's been a lot of outbreaks within schools. So we're also helping the Ministry of Education with the children in terms of controlling of the infections within schools. And also the artisanal miners, they were also being capacitated with the information, especially in terms of washing their hands, putting on their masks regularly, and also in terms of the market the vendors, the market stalls, where a lot of activities do happen. So it was a lot of engagement and a lot of activities which our behavior change facilitators were doing, also providing them with PPE as well, making sure that the communities are also safe. Next slide. And in terms of vaccine uptake, the leaders and the traditional leaders were at the forefront in terms of vaccine uptake, and also getting the community feedback as well. We did collect a lot of feedback in terms of social listening, collecting feedback, the feedback which we were also sharing with UNICEF, and then they would also share globally. So we had to get that feedback and also share it with the stakeholders. And in terms of collecting the feedback, we were collecting the feedback digitally. Next slide. In terms of accounting to affected populations, during the second wave and the third wave, we're also tracking rumors and trying to make sure that the misinformation and disinformation which was already there within the communities was also dealt with, because you'd find that a lot of misinformation also started within the faith community. So we also had to counter that misinformation, engage with the leaders, give them the proper information so that they would be in a position to share the proper information back to their congregants. Next slide. And in terms of key results, as AWET, we managed to train 3,744 behavior change facilitators. We trained 715 counselors, 1,570 traditional leaders, 850 faith leaders. And from the 850 faith leaders, there was an endorsement in terms of them being the frontliners against COVID-19, and also being the, the message carriers in terms of the misinformation which was there. We managed to do national campaigns on radio and on TV with the faith leaders, and different of them had to come on national television and radio in terms of trying to raise awareness and encourage vaccine uptake. And we also managed to produce different materials for information, where you can also go on our website and you can check in terms of our information hub, which we've got in terms of COVID-19. And we managed to document testimonies within different religious groups, even within the religious objectors. Next slide. Thank you very much. This is what we have managed to present as AWET, but over and above, you can even check our social media platforms. There's a lot of work that we have done. You can even check with UNICEF. There's a lot of work that we have done in terms of COVID-19. Thank you.
Thank you so much, Mrs. Kudo. I would like to call Mr. Onias Ndoro, who is the Director for Traditional Religions in the Ministry of Health and Childcare, And I'm also kindly asking if we could make our presentations as short as possible because we are running out of time. Would like to take some questions that have been posted in our chat box. Thank you.
Thank you very much, and greetings to delegates. I'm going to make my presentation brief because some of the issues that probably I wanted to talk to have been already presented by other presenters, but therefore I'm going to focus more on the African traditional religion, because I note the other religions have been adequately addressed. My name is Bonias Ndoro. I'm the director for traditional, complementary, and integrative medicine in the Ministry of Health. And I'm delighted to be part of this conference. Like what has been said before, you are aware that Zimbabwe is predominantly a Christian country, and as such, above 80% of the population are of the Christianity religion. Basically, our engagement approach as Ministry of Health has been mainly through dialogue with the religious leaders and also faith-based organizations and faith communities, because we believe that these stakeholders are quite key in addressing many known barriers to the uptake of health and other essential services, including immunization and also vaccination against COVID-19. The main role of the faith leaders, we believe, is mainly through advocacy. We believe that faith leaders can actually advocate for vulnerable groups, and also they can also assist in terms of fighting against messages which misinform the public. We believe also that they have a key role in terms of education for distributing correct messages from the national key players, that is Ministry of Health and its partners, in terms of disseminating information. And therefore, we view that faith leaders are key. But I would like to talk more on the African traditionalists who are also recognized by the Ministry of Health and have their own council, which is the Traditional Medical Practitioners Council. And they also have their own beliefs, and as such, you find that they have also put so many claims in terms of possible cures for COVID-19. So working with the WHO, the ministry adopted a master protocol that was developed in the WHO Afro region for the possible validation and conducting of clinical trials related to traditional medicines that may have been proffered by traditionalists. And I'm sure you are aware that during the pandemic, because most people are in the panic mode, you find that use of home remedies was quite high during various waves of the pandemic. And as such, ministry had to actually coming to educate the traditionalists in terms of the dangers of promoting unvalidated or scientifically proven home remedies to the public. So you find that the ministry engaged various faith leaders in terms of training for various activities they do in the community. And this included the things like funeral management, and also it included also issues related to social distancing during gatherings when permitted by government, or also in terms of promoting implementation of low technology communication where possible. So in terms of traditionalists, you will find that the ministry trained more than 400 traditionalists in terms of contact tracing, in terms of infection prevention, and also in terms of implementing the guidelines that have been proffered by WHO and the Ministry of Health. And to that effect, those traditionalists that were trained were equipped with the gadgets such as the thermoscanners and also masks and other things that they could use in terms of the contact tracing. And we note that through the rapid teams on the ground, that they also played a key role in terms of presenting cases that would have actually been picked by the traditionalists to the rapid response team on the ground. And they also played a very important role in terms of being role models. Both the Christian faith leaders and the traditionalists could come up openly to say, I'm going to be vaccinated, and made it publicly to make sure that the public can see them or view them being vaccinated, and also to make sure that they can influence their congregants to actually go and get vaccinated. However, this also had challenges. We have been engaging traditionalists and faith leaders for some time, as has been alluded by other presenters. But this comes with challenges. And the challenges include, for example, divergent views in terms of disease etiology by traditionalists and also by faith leaders. So once that situation arises, it becomes difficult for them to then implement the protocols and the guidelines that we have been proffered by the ministry and its partners. And also, in some cases, faith leaders are afraid in terms of losing their congregants when they implement some of the suggested methods, because they fear that they may lose power. And as such, there is need for continued engagement in terms of dialogue with the leaders of the faith-based organizations and also traditionalists. I think this is what I can share with the delegates at this point in time, since most of the issues have been presented by other presenters. Thank you.
Okay, thank you so much, Mr. Ntoro. We are kindly requesting all the panelists to respond to the questions that are being shared in the chat box, as we no longer have time to take the question and answer section. At the moment, I would like to call Ms. Rumbidzaichi Mukangara, who is a health promotion manager in the Ministry of Health and Childcare, to give us the last presentation of the day. Thank you.
Thank you very much, Vivian. Good afternoon once again, delegates. I'm going to present on the experience the Ministry of Health and Childcare had in collaborating with faith partners. Next slide. So over the last decades, there has been a shift in the public discourse for the role of faith-based organizations in delivery of public health services. And these faith partners have taken a responsibility to ensure that their congregates have relevant information for informed decision about congregates' health. Next slide. So the core values for our partnering with the faith community, we used issues of trust and greater understanding among diverse individuals, as we talked about that we do have different faiths in our communities. There's also an issue of open and honestness in our communication. Also, mutual trust played a great role in that. Issues of accommodation and compromise, where we do have other faith sects that do not believe in modern medicine, but with engagements and all, they have managed to compromise it sometimes, and we have managed to work with them. There's also generosity of spirit and sharing of resources. As we have heard, most of the faith-based organizations do use funds that they get from the church to help the community, and also maybe from other partners. And lastly, issues of faith and determination, that the process will lead to a greater good, have helped us to continue collaborating together. Next slide, please. So for the benefits of partnering with faith communities, there is promoted information and service delivery for the public. There is strengthened community ties, since the faith communities are the largest and best organized civil institutions in the world. And also, faith leaders are the most respected figures in their community and play a powerful role in shaping attitudes, opinions, and behaviors of their members. Next slide. So why is it important to use trusted voices and influencers during the pandemic? In this period of profound social distrust, we need people who everyone will listen to. We need people who listen to everyone regardless, regarding the COVID-19. So faith leaders have proven to be a voice of authority in the community, and if given the correct information, can mobilize their communities for action. We have also seen them working very hard to improve the uptake of the COVID vaccine. And religious leaders, traditional healers, they've come up on social media, on other platforms, and encouraged people to get vaccinated. Next slide. So in our area of collaboration, we did work with a number of religious groups. We have the Judah Caesar, the SDA, the Catholic Bishops Conference, the Evangelical Fellowship of Zimbabwe. We also have the Supreme Council of Islamic Affairs, then the National Traditional Healers Association, and also for the National Traditional Healers Association and the Dareremwea, Yevadzimu, and also the chiefs. These are some of the people who subscribe to the African tradition religion. Next slide. So in our areas of collaboration, we did have faith-based organization, traditional and community leaders training on COVID-19 for community engagement. In September 2020, these trainings were done simultaneously in Harare and Bulawayo, which are our two regions. We also had faith-based organization trainings conducted in Mashikade. This was supported by Await. I think they talked about training 850 people in all, where there were endorsements that were done after the training. And ZCC interfaith virtual training was done, supported by WHO. Next slide. So these are pictures of some of the trainings we conducted. This is the faith-based organization community engagement training, one in the northern and the southern region. This is just a pick of part of the group. These groups were divided into 4 groups per region. So due to COVID-19, we had to train a small group at a time because of the COVID-19 restrictions. Next slide. So from the community engagement training, we did have a voice of endorsement from the different leaders that were there. They committed to share correct and accurate information for COVID-19 prevention and control to their members. And it was a mandate that they will be the change agents that will educate communities of COVID-19 through various platforms, including at churches, water points, and community meetings. They also pledged to identify and give prominence to vulnerable groups in the COVID-19 response, which include the orphans and vulnerable children, people living with disabilities, and also interfaith collaboration for COVID-19 response and beyond. So it's not only going to stop here with the COVID-19 pandemic, but we now want to continue strengthening this collaboration beyond COVID-19, so that whenever we have health programs, we always work together. And there was also a pledge to form a council of the inter-religious council of churches, so that all the churches work together and interact, and open a door for recognition, acceptance, and collaboration with Ministry of Health on health and other key stakeholders through local structures. So this collaboration will not only stop with the Ministry of Health, but with other key stakeholders in the community, so that we do work together at a larger scale. Next slide. So this was also the ZCC interfaith training, which was supported by WHO and Ministry of Health, took part. We did have national trainings, provincial, and they are going also to be cascaded to district level. Next slide. So from the ZCC interfaith workshop, we also had action points, which were for the interfaith leaders to encourage the testing of COVID-19 in the presence of symptoms and hospitalization or home management after testing positive, limiting physical presence as much as possible. So they pledged to either use phones, Zoom, or Teams to have some of their meetings, and also maybe to follow up their congregates virtually, and also regularly disinfecting of services between church services, getting tested and vaccinated at the nearest health facility, reporting suspected cases, and also self-care and stress management for the interfaith leaders themselves, since they were, especially in the third wave, there were a number of deaths occurring. And you know, in Zimbabwe, most funeral proceedings are led by the interfaith leaders. So they also needed some self-care and stress management due to that. Next slide. So for the roles played by the first faith leaders, we have information sharing with members about health issues, avoiding faith or traditional practices predisposing individuals to COVID-19. Like in Zimbabwe, most of the prophets pray for people while touching them, and they will be shouting and they will be close to them, maybe without wearing a mask. And this was quite a risk that was noted. So they pledged to avoid that, adhering to gazetted COVID-19 restrictions permitting to church gatherings. As of now, church gatherings are now allowed for those who are vaccinated. Encouraging uptake of COVID-19 vaccine and accepting the COVID-19, that COVID-19 needs scientific intervention. And this was a best practice because we have traditional healers that were often saying they have cure for quite a number of diseases, maybe malaria, whatever, and people would get to the health facility late. But with engagements, especially during this COVID-19 vaccination, COVID-19 pandemic, we did engage them early, and they accepted that there has not yet been a cure for COVID-19. Thank you so much.
Vivian, I'm afraid you're on mute.
All right, thank you so much, Mbidzai, and thank you to all the panelists that came through with such rich information. I'll give back the mic to Sarah Hayes to take the last part of this conversation. Thank you.
Thank you, Vivian, and really a really big thank you to you, because I think without you, this webinar would not have happened. You really are the one who's pulled it all together. So it's been wonderful to work with you on that. Unfortunately, and I'm very sad to say it, we have run out of time and we won't be able to have a Q&A, but it's been a very rich discussion with very rich presentations from everybody. And I'd like to just remind everybody that this event is, it's a standalone event, but it's part of a much broader piece of work. And we will be writing up these case studies because there is so much to learn from them. And we look forward to sharing those write-ups with you at a later stage. The recording will also be available on YouTube for people to watch afterwards. And I just wanted to say thank you to all the presenters and panelists today, our colleagues at the WHO Country Office in Zimbabwe, our colleagues from the Ministry of Health, and of course the faith partners who are doing such incredible work within communities. Thank you. It's been a real pleasure to listen and learn from you today. So Dr. Francis Curia, the co-host, I know you're kind of on the move on your way home, but if you are still online and available and would like to just say a goodbye and close this, please, over to you.
Thank you very much, Sarah. I'm still here. It was such a wonderful discussion, such a rich sharing of what is happening with the religious actors in Zimbabwe, and really good for both UNICEF and Dr. Mtata to mention our launch yesterday. It was a beautiful event with the Minister of Home Affairs for the Zambia Interreligious Council, and I believe they'll grow from strength to strength in serving their communities. So what a wonderful culmination of that launch event, that we are discussing how religious leaders can serve their community better in the times of medical emergencies. So thank you. I really appreciate. My battery is going very low, so I might go off anytime. So thank you very much, and God bless you all. And it was a pleasure to be with you today. Thank you.
Thank you. And thank you everybody for your time. And we look forward to continuing the collaboration and the conversations. So stay safe, everybody, and thank you.